Apple Podcasts, Facebook, Twitter, and Instagram. We hope you enjoy this episode. In today's episode, we interviewed Dr. Jason Kirby, a specialist in addiction medicine. He'll talk to us about why he chose the specialty, how he got started in osteopathic medicine, and how all stories come full circle. We know you'll enjoy this episode.
Dr. Jason Kirby, welcome to the show. We are excited to have you.
Okay, thank you, Mike.
Yeah. Can you tell us what addiction medicine is and what someone like yourself does on a daily basis?
So addiction medicine is really the diagnosis, the prevention, and the treatment of all addictive disorders. And nowadays, when we talk in 2026, primarily substance use disorders. But I do like to point out to my colleagues that really all addictive disorders, we are the specialists for everything that hits our limbic systems, our brain motivation centers. So that includes gambling, sex, pornography, gaming addiction, anything that has that compulsive type of behavior associated with it. So we're trained to, like I said, prevent, diagnose, and treat and be the experts in this space, and super happy to do it. I've been doing it the better part of a decade now, and I'll be doing it till I hang up my stethoscope for sure. My role is a little bit different than it was, say, 2 or 3 years ago. I currently am the Chief Medical Officer for Recovery Centers of America. We're the third largest drug and alcohol treatment organization in the country. We have 12 sites in 6 states. And we're expanding our service lines to also incorporate primary mental health, residential care. So for folks that don't have addictive disorders, they have mental health illnesses. So we can incorporate care for those folks. And we also are expanding care into outpatient sites too. So we currently have 3.7 ASAM levels of care, 3.7, 3.5, 2.5, and 2.1, which are, like I said, or most of the inpatient and outpatient levels of care, as well as primary mental health. I don't practice medicine like I used to anymore. I don't see patients. In my experience, I've seen probably thousands of patients in my career in the 10 years I've been doing this. I started off my career as an addictionologist, who just saw patients. I remember my first day as medical director for Western Pennsylvania's oldest and largest residential organization, and saw patients with opioid use disorder and stimulant use disorder, alcohol use disorder, a lot of the different use disorders at the time. And my goal would be to optimize their care, get them into treatment, optimize their treatment plan, make sure that we address not only their medical and psychiatric needs, but also their behavioral needs. So there's a lot of behavioral change that goes into a recovery program. A lot of times we need to get past some of these compulsions, and it can be very difficult to do. And so we have kind of a cognitive strategy to do that. And also keep in mind too, that around 70% of these are folks with a diagnosed addictive disorder have some element of trauma in their past. It's kind of peanut butter and jelly. So we also have to make sure that we're at least starting to address that as well. Or, return to use can be a big problem for folks. So very complicated facet of medicine, but I'm very excited about the future, as opposed to 10 years ago when we were a lot more wild. We kind of have our act together. Physicians can now get board certified in addiction medicine through the American Board of Preventive Medicine, which is an allopathic ACGME board. There are also fellowships in the AOA version of addiction medicine. So the American Osteopathic Academy of Addiction Medicine, the AOA-AM. I'm faculty in both and leadership in both. And I've trained dozens of physicians to become amazing addictionologists. Really, at the end of the day, just lastly speaking, this field kind of is what you make it. I'm a little bit different. I love the cognitive-based treatments on patients. My practice, I've always incorporated a lot of other behavioral addictions and process addictions into treatment, same as substance use disorders. I've been medical director for opioid treatment programs, and I've been medical director for residential treatment programs. I was even the chief of behavioral health for a hospital-based program. But, a lot of different physicians, especially when they come out of fellowship now, they kind of can pick their path. They pick their path where they find the most interest, whether it be inpatient, outpatient. There's a lot of opportunities in residential units. There's a lot of opportunities in federal opioid treatment programs. And then there's also some policy opportunities as well. So, the future is bright. for physicians just getting out of residency.
When we have people that come and lecture, a lot of them are internal medicine physicians or family practice physicians who have done extra training in addiction medicine. So is it a standalone residency at this point, or is it something that you need to go through the internal medicine or family medicine residency and then work your way into addiction medicine?
So addiction medicine is a subspecialty. And like I said, primarily it's a subspecialty in both the AOA and ACGME. So yeah, physicians can do their primary residency in family medicine and internal medicine. I've also seen OBGYN, emergency medicine. We also have fellows in pediatrics. I've seen anesthesia, primary boarded fellows in addiction medicine, psychiatry, by the way. So yeah, we kind of take all comers because again, in every field of medicine, in every facet of medicine, you're going to have patients who struggle with behavioral disease. You just will. And because of that, we're kind of a subspecialty that really is right for everybody. Now, interestingly enough, when I first got into the gig 10 years ago, I would say that the majority of membership in ASAM is our professional society, the American Society of Addiction Medicine. I would say that the vast majority of membership was psychiatric. I would probably say 60-ish% would be psychiatric. But an interesting turn has happened to the field where the psychiatrists, they don't invest as much resources during residency into training for addictive disorders like they used to, because there's new and evolving evidence looking at the triad of healthcare. Whereas there used to be mental health and physical health, now we have mental health, physical health, and there's a triad into a behavioral health, right? Because behavioral health is really facets of each. Plus, the psychiatrists also have their own fellowship for addiction psychiatry, and they leave a lot of the addictive disorders up to these folks. And so, yes, whereas 10 years ago, the vast majority of membership in ASAM was psychiatric, it's kind of turned on its head. Today, in 2026, 60% of our membership in ASAM are actually medically trained. So internal medicine, OBGYN, family medicine, things like that. And that's kind of what I would predict, in the next few years will probably continue along that trend. Again, the psychiatrists have their addiction psychiatry fellowship to chase, and addiction medicine is a 1-year fellowship. There are currently 127 ACGME accredited fellowships in the country. Most fellowships will take anywhere from 2 to 3 fellows per year. And fellows can expect a pretty robust continuum of core requirements. So they'll spend time in the hospital doing addiction consults. In the hospital, they'll spend time in opioid treatment programs. They'll spend time in residential programs. And then there's some elective space too. So if there's any other facets of healthcare that the fellow thinks would be helpful for them in their career. Some fellows do pediatric rotations. They'll do child and adolescent psychiatry rotations, wanting to get that more complex depth of psychiatric knowledge. So really, like I said, in 2026, it's a really good opportunity for fellow to kind of chase what they're interested in and become the addictionologist that they want to become. And if they want to incorporate psychotherapy like me, do a lot of the process and behavioral addictions, there's room to do that. If they want to be the medical director of an opioid treatment program, there's room to do that. If they want to be the chief of behavioral health in a hospital system and have a hospital consult service, they can do that. So it's a pretty cool time.
In addiction medicine, I know that we use person-first language and trying to destigmatize addiction. So as a future training physician, how should we go about destigmatizing addiction and the behavioral health conditions that you specialize in? And where do you see the stigma in society that's harming the patients the most?
I don't say to folks that the opioid epidemic in the 90s had a lot of positive aspects, but I will say one of the positive aspects that it did have is the amount of money that's being soaked into primary research from the National Institutes of Health and some of these other governmental entities. We're, for the first time in addiction medicine space, we're able to actually do randomized controlled trials and actually look and see, what is helpful and what is not showing to be helpful. So we are the most scientific that we've ever been as a field and a specialty. And so I'm very thankful for that. And one of the things that we've learned recently is that the language that we use when we talk with patients, and not only patients, but when we talk with each other, the language that we use can affect a person's outcome, and when you use that term stigmatized, some of our language like addict, alcoholic, rehab, druggy, clean, not clean, some of these antiquated terminology that we use that we've used for years, to be honest with you. And again, I would also echo, a lot of people are not using this language to be negative, but they do have a negative connotation. There was a few studies published back in 2018 that looked at this language and looked at retention in treatment, meaning that the question was, is there a difference in how long a person engages in treatment depending on the type of language that's used in these treatment facilities? And the answer to that question was yes. And in fact, it does. In fact, when we use some of these more negative stigmatizing terms, patients tend to stay less, right? And the goal of any chronic disease is to engage people in treatment for as long as possible. They don't need to be in a 30-day residential program for their entire lives. But again, no different than hypertension, there needs to be some sort of connection to make sure that we're adequately assessing folks and then hopefully catching them if they do start to destabilize early on, and do some early on interventions to lessen the severity of that return, right? No different than somebody with other chronic diseases. So we have to be very careful. There were two studies in 2018, and there's actually a list of terms that they published. I'll try to look for you. And again, all sorts of different terms that make sense, but also some that folks may not have associated with negative connotations, like the term Suboxone, for example. The term Suboxone has been shown to have some negative connotations just because so many people have used it, with so many patients have attributed the term Suboxone to other negative aspects of treatment in the past. So me personally, when I'm speaking to you or anybody else or to patients, I will do my best. And again, I'm from the old school, so this has been a difficult and challenging transition for me. But I will do my best to try to prevent any type of stigmatizing language from leaving my mouth. So I'll say residential program versus rehab, or I'll say buprenorphine, which is the active medicine in Suboxone. Suboxone is the brand name medicine. I'll say urine positive or urine negative as opposed to clean or dirty. I'll never use the word addict. I've never used that before, and I never will. But I'll say a person with a substance use disorder or a person with an opioid use disorder. And again, the goal, I think society's goal at this point in 2026 needs to be, we need to make sure that we are, when the way that we refer to addiction medicine, that we are normalizing addiction medicine as a part and field of the greater healthcare system, right? When folks go into their PCP for a cardiac check, right? They're getting a stress test, and they're getting this cardiac workup. There's no negative connotations around that, right? There shouldn't be for somebody who's being screened for their emotional attachment to drugs and alcohol or substances and alcohol. So we just need to normalize having these conversations. So when a person comes in, we say, hey, let's talk about your relationship with alcohol. And it should be a normal thing to talk about. And I think we're better than what we were 10 years ago. My hope is that with all these new physicians that are coming out of fellowship now and training the students in medical schools, and that every year will just be better and better and better. And then eventually we can get as a society to really normalizing this disease for really what it is. It's a brain disease. It's a primary brain disease that has a very predictable pattern, just like other chronic diseases. And so it's just something else that we need to make sure we optimize in a patient's life.
Can you tell us a little bit more about your involvement in advocacy, policy of medicine, and what are some of the changes that are happening right now that you're most excited about? I know that we've talked about the training of current fellows and medical students as well as residents. What else are you most excited about?
Again, over the past couple of years, the trajectory of my career has been a little bit different. Again, kind of going from taking care of a person to taking care of people. And my policy work has kind of reflected that. I'm a recent graduate, the American Academy of Colleges of Osteopathic Medicine, AACOM. They have a health policy fellowship program offered to not only DOs, but primarily DOs. And that was just such a wonderful experience. And it gave me an opportunity to meet with other policy-minded physicians and really explore policy in certain states. We went to Ohio and Washington, D.C., looked at federal policy. We went to Idaho and looked at their policy. And we were hosted by a lot of these osteopathic schools. And it was just a really awesome opportunity to look and compare and contrast some of these state policies, especially when it comes to, for me, mental health. But we also talked about other facets of medicine. Reproductive health is a big conversation we're having nowadays. How does Idaho do it differently than California, for example? And they do very different policies between those two states. But again, mental health, very, very different in Ohio versus Idaho, per se. And so it was very interesting for me to grasp of that. I also used that experience when I was president of the Tennessee chapter of ASAM, Tennessee Society of Addiction Medicine. I had a 2-year term, which actually ended last April. And I was always in Nashville talking with our state politicians, really about everything surrounding mental health and addiction treatment, and really optimizing how we did treatment in the state of Tennessee. And it really gave me a foundation to be able to talk with politicians and really take my own emotionality out of it, which can be very difficult, right? When we're passionate about something, it can be very difficult to not let that passion kind of sway a conversation. And, when you're talking with a politician, with a stakeholder, they may not agree with your position. So you may not get everything you want. I think the goal in policy is to come and meet at a certain point and see if that we have some common themes that we can put together for an idea. How can we best take care of folks? That was a super rewarding experience, both the fellowship and my time as president of TNSAM. Those are two things that I'll remember the rest of my career. And so nowadays, I've relocated up to Pennsylvania. I am engaged in the Pennsylvania Society of Addiction Medicine. I'm on the legislative committee here. And we're talking about policies related to very, very similar in Tennessee. There's actually a bill right now in committee in Harrisburg looking at kratom, mirtazapine, which is a substance similar to opioids, not an opioid, but similar, that has been very, very detrimental for a lot of folks. And there's some discussion about banning the 7-hydroxy metabolite of mirtazapine. And so it gives me an opportunity to chat with other PSAM members and politicians in Harrisburg and talk from a healthcare perspective, an addiction medicine perspective, and most importantly, a treatment perspective. Okay, well, what are we going to do with these folks once it becomes banned? And how are we going to be able to incorporate all these new patients into treatment, which is not something that all politicians think about at the time they're thinking about banning things. So it's very important for physicians to get vocal. Like I said, most politicians don't think of some of these policy issues from a healthcare perspective. They think banning everything is the only thing that needs done, and then the problem will go away. And that's not always the case. I always like to think when you ban a substance, think of it with the analogy of bathtub with the water running in it, right? So there's two things you need to do to solve the problem to get the water out of the bathtub. Number one, you need to turn off the faucet, which is what banning a substance does. But then what do you do with the rest of the water that's already in the bathtub? And that's where the treatment focus comes, because we need to get the rest of the water in the bathtub focused to how do we incorporate these patients into treatment? What red tape do we need to do from a regulatory standpoint and licensing standpoint? What do we need to do to entice treatment providers from a financial perspective to make it feasible for them to incorporate these patients into treatment as well? So it can be very challenging, but we need as many physicians to do this as possible. And it's not just in addiction medicine that it's relevant. I would encourage all physicians who have a certain passion in medicine to be vocal. And one of the things I've learned that politicians love to speak with us. They don't speak with doctors a whole lot. And when they get the opportunity to hear from us as experts, they really do value it. At least that's been my experience. And encourage everybody to get as vocal both on the state and local level as they can, but also on the federal level if there's an opportunity.
When making those huge policy changes, so that's great.
Interestingly enough, there are two bills floating around right now on the federal perspective. One is a bill called the Modernizing Opioid Treatment and Access Act, MOTA, and it essentially will give the ability of addiction experts, so addiction medicine and addiction psychiatry experts, the ability to treat opioid use disorder in an office-based setting, which has never been done before, right? So to use methadone for to treat opioid use disorder, for the last 50 years, it had to be in a recognized federally licensed opioid treatment program. Problem is there's not as many of those. They're very, very regulated, and there's a lot of barriers to entry for these programs to exist. And so giving experts like myself the ability to do this in an office-based program, so a regular physician's office, treat methadone for opioid use disorder, and to have a patient pick up their methadone from a pharmacy, down the street like they do the rest of their medicines, it's pretty groundbreaking. So we're very hopeful that that bill passes. It currently is stalled in committee right now, but we're hopeful that there's enough support to get that to move. There's also another bill that will be essentially giving residential care, writing a code for residential care for Medicare recipients to be available. As of today, it's shockingly enough, Michael, if you have primary Medicare, Medicare does not pay for residential drug and alcohol treatment. There's no code written for it. And it's just one of these historical things that we've just never corrected as a society. But there was a bill introduced in the last session that we're hopeful for this session to get support on, to be able to write the code into Medicare to give Medicare recipients the ability to come to residential drug and alcohol treatment and to have Medicare pay for it. Because it could be pretty expensive to spend 28 to 30 days in a program. And our elderly Medicare recipients need to have that access no differently than folks with commercial insurance do. So I'm excited for both. I think we're doing really cool stuff in the policy space, both on the federal and state level here in Pennsylvania. And I'm excited to see where addiction medicine goes in the next few years.
Could you just briefly touch on what is your involvement with technology?
AI, I think just in general in medicine, it is here, number one. In the next probably 2 to 3 to 5 years, it's going to be interesting to see how incorporated artificial intelligence is to our daily lives here as physicians. The hospitals are already looking at it. I know a lot of electronic medical records are incorporating it into their physicians' notes to make the physicians' notes be more efficient, give them more time to see patients. In the world of behavioral health, one of the things that has been probably what I would say the holy grail is the ability to use a person's behaviors to predict a return to use. And that's never been done before. It's been very, very difficult. But interestingly enough, people are people, and behaviors, everyone elicits fairly similar behaviors when it comes to obsessing about their drug of choice or being compulsive around their drug of choice. They give clear signs and symptoms that, hey, maybe they're thinking in this way. And I'm hopeful that using AI in the future to better come up with an algorithm to determine, hey, this person is exhibiting X, Y, and Z behaviors. As such, we have a window likelihood that this person's high risk to return to use. We had that information, then we could intervene. We can come up with policies and procedures to intervene with folks in treatment. If they're not already in treatment, we can get them into treatment sooner before maybe even a return to use. Because again, with all substances, return to use can be pretty chaotic, but with opioids, it can be deadly. So to prevent a return to use would be optimal. That would be the holy grail. And so I am very hopeful. I've worked with a number of organizations in the past who are looking at algorithms with AI to better determine and get to a place where we can predict a person's risk of return to use based on their behaviors. And I think it's going to be, again, it's another cool aspect of medicine in the next couple of years. One thing I can tell you, Michael, the company that does invent this algorithm will win the Nobel Prize, because that will be something that will be no less groundbreaking than the polio vaccine from Jonas Salk.
When people hear the word addiction or substance misuse, they think drugs, alcohol. What about people with eating disorders, gambling, pornography, even sex? So how do you feel, is there enough being done as of now? And where do you think that could progress to help those patients that aren't necessarily dealing with drugs or alcohol per se?
Yeah, no, interestingly enough, and that's a great question too, Michael. At the end of the day, what I would love for your listeners to really, if they hear nothing else, addiction is simply defined as doing a behavior that is producing negative outcomes but doing it anyway, right? And continuing that behavior. It's the definition of compulsion, by the way. That's exactly what definition of compulsion is. So my point is that whether you're using opioids to make yourself feel better or cure your depression or make your life a little bit less stressful, which is why a lot of folks use substances, or you use gambling to do the same thing. All addictions hit the exact same parts of the brain, whether it's an opioid, whether it's gambling, whether it's your cell phone, right? And there's a lot of evidence looking now at gaming addiction, and it really is becoming a big problem. And because the mechanism is exactly the same, everything runs through our reward motivation system in our brains, our limbic system, we can predict the treatment algorithm is going to be very similar too. And that's really what we're finding, right? There are some medications that can help the biological drive, especially around withdrawal. Opioids have a very nasty withdrawal. It can be very, very difficult to get folks past that. So we have medicines to really help with that and to help with the cravings. The way that I talk to patients about cravings, think of it like you and I are trying to have a conversation, Michael, and I'm blasting Metallica in the background and Master of Puppets. I see you're moving and I know you're talking, but I can't really hear you. And that's kind of what it's like for somebody, especially early on in recovery, when they're being so bombarded, their brain's being so bombarded with these cravings. Like they're in treatment, they may be at these residential sites or these outpatient sites and they're engaged in treatment, but they're not listening. They can't hear what somebody's saying because their cravings are too loud. So what a lot of these medicines do is they turn down the Metallica, they turn down the volume, and they never turn it off. That's important. They never turn it off, never gets turned off. But it can get to a volume low enough where you and I can start to engage in a conversation, Michael, and then really start the process of changing the behaviors that are necessary to get rid of the addiction. And that's the important part of a treatment program. It's not just not using a substance. If that were the case, then everyone who went to jail would no longer have their addiction. And what we know that's not true. Just taking the substance or the behavior away does not rehabilitate the person. The person has to learn to essentially a brand new set of behaviors and neurocognitive pathways of how they think to be able to stay away from whatever, whether it be a substance or another behavior process, whatever the case may be, that started that compulsion. So that's why this is not a one-day treatment, right? This is a chronic illness and patients should be in treatment the majority of their lives in some aspect or not. So getting back to my original point, whether it's opioids or alcohol or gambling or gaming, because it runs through the same pathway, it has a similar treatment approach. And so again, the goal is to decrease the compulsion. It's to decrease the automaticity of the thought processing. How can we reincorporate different values? How can we reincorporate a sense of ethos to the person where they're entrusting themselves to develop other behaviors that might mimic who they want to become, who they are, who they want to become. So there's a lot that goes into it. One of the things I'm most excited, though, that's currently being trialed right now in the field of addiction medicine are these GLP-1 agonists, semaglutide and tirzepatide and these other GLP-1s. Interestingly enough, obesity, I've been a proponent of adding obesity to the DSM under addictive disorders for years now. I mean, fundamentally, you can't become 600 pounds without some sort of emotional dysregulation with your relationship with food. It's just impossible. And so obesity does have a kind of an emotional component to it. And these GLP-1s are recalibrating. I wish we had enough time to really go through the biomechanics and the biophysiology of it because it's fascinating, but it's essentially recalibrating the limbic system and the dopamine drive from the stimulus that happens. And it's making it easier for folks to lose weight, but not only lose weight, it's easier for folks to put down the alcohol and the opioids just in and of itself. And so the opportunities to affect methamphetamine and other stimulants and alcohol and tobacco use and opioids and all other aspects of anything that runs through this dopamine system, this limbic system, the opportunities are very interesting. And there's a few NIH studies that are happening now at some academic centers looking specifically with opioid use disorder, with alcohol use disorder, and they're showing very, very promising early findings. So my hope is that The findings continue. We see a significant difference in patients who use these GLP-1s for all addictive disorders. And then we can start to drive down some healthcare costs. How nice would it be for more patients to stop smoking and keep off the tobacco? How nice would that be for our healthcare system? Tobacco being the number one cause of preventable death in this country. I'm really excited about the future with GLP-1s, and I'm very hopeful that we start getting this data here in the next year or so.
Switching gears a little bit, where did you grow up? When and how did you become interested in medicine, and what led you to be an osteopath?
I grew up in the coal fields of West Virginia. I actually grew up in Lewisburg, West Virginia, which the West Virginia School of Osteopathic Medicine was literally in my back door. I grew up about 12 miles away from WVSOM, and I remember growing up, my pediatrician was a graduate of WVSOM and playing sports in school. A lot of my sports physicians were graduates. I knew the school very well. I just knew they trained their folks incredibly well. I wasn't really interested in medicine until I would probably say the end of high school. My plan was I was going to play football, make it on a football scholarship somewhere. Then you get hurt, or I got hurt, and the phone calls stopped coming, and had to figure out some other solution. And I remember I just have always been really interested in why people do what they do and the human body. Just really fascinated with how the human body works and all of its intricacies. After high school, I went to West Virginia University, and I was a biology major and a psychology major. And in 4 years, I graduated WVU, and I applied to a few different medical schools, applied to West Virginia and Marshall, but I also applied to WVSOM. And I told my folks that if I get selected at WVSOM, that's where I would go. Not that there was I had anything against WVU or Marshall, but I loved where I grew up, and I knew the caliber of physicians that they graduated, and I knew I would receive a really good education there. I'd be able to do what I wanted to do in medicine, and I'd get a chance to be close to home too. So I ended up going to Lewisburg, to WVSOM, and I didn't know exactly what I wanted to do in medicine. I'm one of the first folks in my family to go to college, and so all of this was new to everybody. But I got an awesome opportunity through my clinical rotations to try out a bunch of different shoes. I like to describe it with family medicine and hospital medicine, psychiatry and surgery, and all these different things. And I ended up deciding that family medicine was probably as close to what I could envision myself and what I wanted to do with my career as I could. So the nice part about family medicine is kind of a jack of all trades, and you kind of get to decide what aspect of medicine you really want to focus on. And I always loved the ability to see one thing one day and then another thing the next day. And so that was always super enticing to me. So I did my residency training at the University of Pittsburgh Medical Center, and wonderful 3 years there. And when I got out, I primarily did emergency medicine, but I also did a little bit of family medicine. It just didn't fit. Around this time, especially in the emergency room, I was staffed around hospitals around Western Pennsylvania, and I was seeing all of these opioid overdoses come in, and these folks with pretty debilitating substance use disorders come in. And I had a wonderful training all the way up through medical school and residency. But unfortunately, again, 20 years ago, there just wasn't the extent of training in behavioral illness as there is now. And I just felt like I just didn't know how to take care of these folks. And so I went to go back and do a fellowship. We didn't have addiction medicine fellowships back then. This was the days before that. But I ended up finding 2 addiction psychiatrists who were nice enough to allow me to kind of apprentice them. And they taught me everything from complex psychiatric medicine to how to incorporate mental health care into physical care. And I was hooked. I did that for 9 months on top of working in the emergency room. And I fell in love with addiction medicine. And I told myself and my wife that this is what I wanted to do the rest of my life. This was the option. I would like to have thought that if addiction medicine were the option, if I knew about it in medical school and residency, that I would have gravitated towards that. But again, unfortunately, these were the days before accredited fellowships. And so I had to discover it on my own, but I'm glad I did. And I just haven't looked back since, Michael. I've been kind of climbing the rungs of the ladder. I started off, built a practice, an office-based practice, primarily treating substance use disorders. And then I was hired as the medical director for one of Western PA's oldest and largest residential programs. Did that for a few years. And then I went up to Albany, New York, and I was the chief of behavioral health for a hospital system up there. Got a chance to do some really cool stuff up there. I started an addiction consult service in a couple hospitals, got a chance to integrate the rest of the medical staff with addiction medicine. And how do we work together with our infectious disease docs and our OBGYNs and our neonatologists and our ICU attendings for complicated withdrawal. It was wonderful experience. Got a really good opportunity to spread addiction medicine into the hospital system. And then I moved on to more leadership opportunities in addiction medicine. I moved to Tennessee and I started as a chief medical officer for a regional Midwestern regional-based residential organization. And then I transitioned to chief medical officer for a virtual organization that primarily did a lot of digital-based therapies, which was wonderful. And then now I've just moved on about a month ago as the chief medical officer for Recovery Centers of America. And it's been a wonderful transition so far. I've had a wonderful career. Like I said, I've treated thousands and thousands of patients with all sorts of addictive disorders. And I'm so excited being in a role now where I can affect people, not just a person, but people and populations. And I can build programs that are going to affect care and provide transformational experiences for folks. My goal has always been to integrate more complex psychiatric and medical care into behavioral care and really treat person from an osteopathic point, really treat the person as a whole rather than have these siloed, okay, this is mental health, this is behavioral health, and this is physical health. No, we're going to admit somebody, we're going to primarily treat them for their behavioral needs. Oh, by the way, they have undiagnosed hypertension or diabetes. We're going to work on that. Oh, by the way, they have a mood disorder or undiagnosed bipolar disorder. We're going to treat that. We're going to treat the whole person. And that's one of the things, back to your point about osteopathic medicine, that I gravitate to so much. The body is a unit. And I've always believed that. And Lewisburg WVSOM solidified that for me. And I'm getting a chance to really reflect that in how I treat patients and systems now.
Lastly, what is the best piece of advice, most inspirational piece of advice you've been given, whether grade school, college, medical school, fellowship, residency, something that inspired you?
Actually, I'll say two things. When I was a young attending, one of my colleague attendings in the emergency room, he said, talking to a patient who just unfortunately just was not doing a very good job taking care of himself. And he said to this patient, I just want you to know, nobody will invest more in your health than you. And I just thought that at the moment, it provided some authority, right? It provided, okay, I'm responsible for my body, my mind. And if I want to optimize my health, it has to be up to me. And to let other folks do that, it just won't provide the same outcome. So I thought that was really, really inspiring. And I've remembered that all my career. But the other thing I would say actually came from my dad, which was, there's two rules in life, son. Number one, don't sweat the small stuff. And number two, everything is small stuff. And I think it gives a really good opportunity just to kind of sit and reflect and give perspective. There's so many things in life that require my attention, and I have to remember that I have finite resources, and I have to make sure to give the attention to my most important people in my life, which are my kids and my wife. And so perspective is everything.
All right. Well, Dr. Kirby, we really appreciate you coming on the show today, and I know the listeners are going to love this episode.
All right. Well, thank you, Michael. I appreciate it. Take care.
This concludes our episode of Do or Do Not. Send all inquiries, comments, suggestions, and even let us know if there's someone you want us to interview to doordonotpodcast@gmail.com. Don't forget to like us on Facebook at Do or Do Not Podcast for updates. If you enjoyed our podcast, please share it with your classmates and administration. We have plenty of more interviews lined up, and we're excited to share them with you. This is Tian Yu Shea. Thank you guys so much for listening to Do or Do Not.